Hello, everyone. I'm Marsha Mott, and welcome to the UF Health Wellness University webinar. Thank you for joining us today as we bring awareness to an illness which kills more than 270,000 Americans every year, including 6,800 children, sepsis. September is National Sepsis Awareness Month, and we hope this webinar will help inspire you to take time to learn the signs of sepsis. I'd like to introduce you to our expert on sepsis, Dr. Phil Efron. Dr. Efron is a professor of surgery and anesthesiology at the University of Florida College of Medicine and the medical director for this UF Health Shands Hospital surgical intensive care units and the respiratory therapy program. Dr. Efron established a critical care fellowship program at UF in 2010, which he currently directs. He's also an advanced trauma life support instructor and has been selected for committees and leadership positions in several medical societies. He co-directs the Laboratory of Inflammation Biology and Surgical Science and focuses his research on inflammation and immunology in severe injury and infection. Dr. Efron has created novel methodologies for studying trauma and further developed the laboratory sepsis research to include well-known factors associated with mortality, including blood product transfusion and aging. In addition, he has led the Translational Human Studies in Trauma and Sepsis at UF Health's Surgical Intensive Care Unit. Dr. Efron joined UF Health's Acute Surgery Department in 2008 after completing his critical care fellowship training at Washington University in St. Louis. If you have any questions for our speaker today, you can submit written questions at any time using the Q&A button at the bottom of your screen. At the end of the presentation, I will ask questions anonymously, and we're going to try to get to as many questions as we can. Dr. Efron, I'm going to go ahead and turn it over to you now. Thank you so much for joining us.
Thank you for that wonderful introduction. It's an honor and a pleasure to be here today. I'm going to share my screen. And please, Marsha, let me know if there's anything wrong. So as mentioned, my name is Dr. Philip Efron. I'm a professor in the Department of Surgery here. I'm the director of the Laboratory of Inflammation Biology and Surgical Science, and I'm one of the executive directors of our UF Critical Care Organization. And I do have a specific interest in the research and understanding of sepsis itself. So let's talk about sepsis in 2021. Oh, there we go. There are no disclosures. This presentation does not promulgate the off-label use of any United States Food or Drug Administration approved medication or devices, and there are no financial disclosures or conflicts of interest. We do have National Institute of Health funding, but it's not relevant specifically to what I'll be presenting today. We also invite you to visit our website, as you can see here, and this is a recorded lecture. So if you're not able to take a photo or write this down, you can always go back and look at it later, but ufhealth.org/sepsis, where there's some good information on what you need, as well as some other links that could be helpful to you and your loved ones. So where do I work? I work at the UF Health Critical Care Organization. What is that? It's not that important for this talk today, but what you need to understand is that at UF Health, we're trying to go above and beyond the normal ICU care that you might expect in any hospital. We have come together as a multidisciplinary group to guarantee that regardless of what intensive care unit you go to, you're getting the optimal care. And that will include patients who are in sepsis or septic shock. So what is sepsis? Well, it's been redefined multiple times, but the last time in 2016, it was defined as an infection that leads to life-threatening organ dysfunction. And it's caused by this dysregulated host response to the infection. So again, many of us get infected, many of us get a cold, sometimes we get a urinary tract infection, but our organs don't necessarily shut down. We're able to sort of fight this off and get better. But when your body isn't able to do this and you have a systemic effect from it, that is sepsis. Importantly, sepsis affects more than 1.7 million adults in the United States each year. That is a tremendous amount. And as already mentioned, can contribute to more than 250,000 deaths. That's astounding. And when you think about the entire world, I think the estimate is greater than 10 million per year. Hospital and rehabilitation costs in the United States are thought to exceed greater than 62 billion. But many people have never even heard the term sepsis. If you ask someone, what's a heart attack? What's cancer? What's a stroke? Importantly, they should know these things. They should also know what sepsis is, but many people do not. It is important to remember that every year, September is Sepsis Awareness Month. So I encourage you to go online, look at what's out there. There are multiple organizations, including the Sepsis Alliance, that tries to get the word out and help support sepsis research and awareness. Now, many of you may not know this, but sepsis is the most expensive in-hospital medical condition. So not necessarily osteoarthritis, not heart attacks, acute myocardial infarction, not issues with newborns, but sepsis. And this is an old thing that demonstrates the 20.3 billion. As you can see, it's almost tripled. Importantly, patients diagnosed with sepsis spend 75% longer in the hospital than those individuals diagnosed with other conditions. So if you become septic, chances are you're going to have a worse outcome. So we need to figure out why people are getting septic, how do we intervene more quickly, and how can we make it so people return to normal and go home. Importantly, sepsis has now been declared a medical emergency by the Center for Disease Control. As I told you, it affects more than 1 million Americans, and it is estimated that up to 28 to 50% of these individuals will pass away. Again, that's astounding. In general surgery, the incidence of sepsis is greater than the incidence of pulmonary embolism and heart attack combined. So again, this is a major problem that patients have that, again, many people are not aware of. It contributes to 1 in every 2 to 3 in-hospital deaths. And again, AIDS, prostate cancer, and breast cancer are very important diseases. This is not a competition, but you need to understand that sepsis kills more Americans than AIDS, prostate cancer, and breast cancer combined. So you can start seeing how massive a problem this is in the United States. What about the outcomes afterwards? Well, among individuals who live independently prior to sepsis, 1/3 die by 6 months after being septic. Now that's astounding, and we're going to talk a little more about that data a little later in the talk. But when you were discharged from the hospital, you can see that you have continuing effects that go on up to a year or two, where you're not necessarily better. And again, of those who survive, a further 1/3 do not return to independent living. So you're not necessarily walking on your own, performing self-care, or eating and doing all the activities of normal living that we take for granted. And then again, another half of these patients may die or not improve by 1 year. And as I said, many of these patients end up not at home independently and require assistance at home or reside in a nursing home or a rehabilitation facility, or often are admitted to acute care hospitals. So the symptoms of sepsis are not caused directly by the germs itself, but our body's reaction to what's sort of going on. And a bacterial infection anywhere in the body may set off this response that leads to sepsis. And this isn't just restricted to bacteria. It can be viral, it can be fungal. Anything that's not your own body could potentially set this off. And the most common infections include those of the lung, which many of you heard about with pneumonia, urinary tract infections, which maybe people have had, or it could be something from the abdomen or gut or your intestines or the skin itself. So common places where an infection might start include the bloodstream. Many of you heard septicemia, that means bacteria floating in the blood. This can be where it starts if you have a catheter that potentially is in your blood or something else that's going on. Bones can have an issue. If you've heard the term osteoarthritis, this can lead to sepsis. Bowel, if you've heard the term again, peritonitis, if something perforates and it's not taken care of, this can lead to an overwhelming body systemic infection. Your kidneys can have problems. Many people have had many people have urinary tract infections. Normally they get better on their own, but depending on who you are, how bad the infection is, this can lead to a systemic body breakdown. In addition, your kidneys can get infections as well, which is the pyelonephritis. One of the more scarier parts can be when your brain gets infected, known as meningitis. This can be very rapid in its descent into sort of bad outcomes. Your liver or your gallbladder can get infected. Many of you, especially with COVID going on, you can get a secondary bacterial pneumonia and your lungs can get infected. And your skin can have cellulitis, or even worse in some situations, what's known as necrotizing fasciitis, where the bacteria start to break down the tissue in your body at a very rapid rate. For patients in the hospital, sites of infection can also include things such as intravenous lines, surgical wounds, drains, sites of skin breakdown, or things known as a bed sore or pressure ulcer. And that's where our ICU care becomes important in the terms of fact that we try to make sure that we minimize lines that aren't required. Our nurses are experts at trying to prevent bed sores and pressure ulcers. And again, the ICUs here at UF Health are trying to make sure that optimal ICU care is given 24/7 to all your loved ones and yourself. Now, if you're watching this with someone, I'd like you to look to your left and now look to your right. Well, chances are they're not septic, but now that I've got your attention, what I want you to realize is that anyone can get septic, although there are some high cohorts that have increased more chances. But understand that every 20 seconds, someone is diagnosed with sepsis in the world. And again, that's an astounding figure. But people who are especially likely to get septic, people with weakened immune systems, so transplant patients, or if you have friends with an autoimmune disease where they require things such as steroids, a TNF inhibitor, something like this. Very young infants, their immune systems haven't developed to the point where they're able to appropriately fight off infections. And the elderly, they're very vulnerable. Many people actually will call sepsis a disease of the aged. In addition, there are certain chronic illnesses that can make you more susceptible. This includes diabetes, AIDS, cancer, kidney or liver disease. These are all types of patients that are at increased risk, as well as those patients that experience a severe burn or physical trauma. After a terrible car accident or a terrible house burn, your body that could have normally fought off an infection can't really do it the way it used to, and they're at higher risk for sepsis. And there have been some unfortunate famous people that have succumbed to sepsis: Patty Duke, Muhammad Ali, and Jim Henson. So what are the symptoms of sepsis? Well, it can be difficult for many people to recognize, as the symptoms may not be specific only to sepsis. However, this can include new onset shivering, fever, or feeling very cold, extreme pain or discomfort out of proportion to what it should be, new onset clammy or sweaty skin, a new onset of confusion or disorientation that doesn't make sense and is not related to something else, shortness of breath, and an extremely high heart rate. But as you can see, these are very non-specific symptoms. In the most extreme cases of sepsis, blood pressure can drop, and this is what's known as septic shock. And this can induce even worse failure of major organs and body systems because of poor blood flow, including but not limited to the organs such as the kidneys, the liver, the lungs, and your central nervous system and brain. So how do we diagnose this? Well, it's done by your physician or one of the medical practitioners. She or he uses a combination of physical signs such as fever, heart rate, and respiratory rate, as well as laboratory values such as white blood count and lactates to determine if the patient is septic. Blood and serum lactates will often be examined. And lactate is not specific for sepsis, but it is a marker of a lack of adequate oxygen being perfused to the tissues. Therefore, if it looks like you are infected and sepsis may be present, this is a sign that you are in severe sepsis or septic shock. So the medical staff will also look at other blood tests if they consider you being septic, as well as stuff from your fluids, your urine, or lung or sputum to evaluate for the presence of infectious agents. So you'll often see the nurse coming to obtain cultures, or the attending trying to obtain cultures from different areas of your body. In addition, certain types of tests, radiographic tests that can help show infection could be ordered as well, such as chest x-rays or CT scans. Timing is key for sepsis. Sepsis is no different than a heart attack or stroke or a terrible trauma where a patient is bleeding to death. All these have been shown to have improved outcomes by doing specific medical therapy within a certain amount of time. And this is usually a form of protocolized therapy, meaning that certain things have to be performed in that time if a patient has A, B, or C. This is a diagram that shows you increasing mortality in those patients that have delay in their first appropriate antibiotics. And as you can see, it just goes up until about 6 hours where your mortality becomes quite significant. So the sooner it's diagnosed, the sooner the team treats it like an alert, the sooner that the whole medical team comes to the bedside and does those things that need to be done to treat sepsis, the much better chance of a long-term recovery you're going to have. So as I stated, there is a significant association between delay in antibiotic administration over the first 6 hours after identifying a septic patient. And then the mortality will continue to increase until appropriate antibiotics, source control, and volume are given. And this underscores again the importance of early identification and treatment. It is a time-dependent condition, no different than heart attacks and stroke, and needs to be recognized as an urgent situation that requires immediate response. All hands on deck, the whole team needs to go. So what is required? Well, luckily, I believe the Medicare and Medicaid have become more involved with our understanding of how significant sepsis is. And now there are certain criteria for patients that physicians, medical practitioners, as well as hospitals need to follow if they've identified someone as septic. So the clock starts ticking, and then what should happen is, again, the medical practitioner should do their assessment, which includes lactate. They should obtain cultures, including blood cultures, and cultures from an area where they think you're infected. And appropriate antibiotics to treat that infection need to be delivered within a set amount of time. Also, within 6 hours, they need to make sure that they've reassessed you and that you're getting better and not worse. Otherwise, other interventions may need to occur. In addition, just to mention that often, but not always, this will require some sort of IV fluid resuscitation, which your body needs acutely in this state to help sort of maintain your blood pressure and perfusion while we fight the infection. So often these patients will be admitted to a place where I work and many of my colleagues work, called an intensive care unit. And in these intensive care units, we have a collaborative care team that treats any organ dysfunction the patient has while the patient overcomes their infection. Sometimes the patient needs an operation, though, to resolve the infection. This is often true when you have abdominal sepsis, where the bowel may have died or you have a perforation of some sort. So one of our premier leaders in sepsis at the University of Florida is Dr. Fred Moore, who's had a very esteemed career in sepsis research. And one of the things he brought here from Texas was his use of protocols. And again, it was very interesting to show that the state of New York, when they protocolized sepsis care, found that there were improvements in outcomes. And this was something that he had shown quite a while back. And this shouldn't be surprising. Not every patient gets the exact same care, but most of them should get certain things rapidly and well done. And this is true, again, whether you're doing trauma and advanced trauma life support, or whether you're doing treating a patient for an acute myocardial infarction or for a stroke. Again, different treatments may be required, but the rapid identification and team work to get those interventions to the patient will allow patients to have better outcomes. What about some of the things that we're doing here at UF as well? Are there alternative therapies on the horizon? I won't get into the very specifics of this because I think it goes a little beyond the talk, but just that we are a sort of major sepsis trial center here at UF Health, working with other national laboratories and hospitals. And we are using different things such as immune modifiers to see if we can get patients better who have had significant issues with sepsis. This also includes something called interleukin 7, which is sort of an immune booster, helps get your lymphocytes the sort of boost they need to sort of come back, because they're usually quite shut down after you have sepsis, as opposed to a regular infection. And again, these are all studies that we're actively conducting with IRB approval and patient approval here at UF, sort of top of the line, sort of best sort of practice kind of things. And again, this is done by our Sepsis and Critical Illness Research Center, which again, we have here at UF Health. Another interesting thing is we're working with the Department of Health and Human Services, as well as different companies, to sort of help with better identification. There are multiple companies trying to work on this to risk stratify patients and determine who needs antibiotics and who doesn't. As I told you, it's very non-specific symptoms. Giving antibiotics to everybody is not a good thing either. And this can lead to overtreatment. It can cause some issues. It can even lead to resistant bacteria. So working with certain companies, one in particular called Inflammatics, we try to use what's in the blood, RNA in the blood, to determine if there's an infection, maybe differentiate the type of infection, and how bad of a sepsis it may be, And this would be a very rapid test. You could run it within 20 to 30 minutes. So that's is an exciting opportunity for the future to sort of help us direct care and get things done more quickly. This is just an example of how it may work. But again, what you would, after sending the test, what the practitioner, the medical practitioner would get is something like you see here, from green to red, helping them make medical decisions based on important information. And that would allow you to sort of determine, is this bacterial versus viral? What kind of antibiotic should I use? Is it neither? Should I not be using any antibiotics because this is something else? So this is the future, and it's here now, and we're sort of working to have it here at UF. So again, we do quite a bit of significant sepsis research here at UF Health and the University of Florida. One thing I want to sort of talk a little more about is that sepsis is a disease of the aging, and I'll explain why I'm going over this in general. But as you can see, over the last decade, from at least 2000 to 2010, and these measurements continue to go out, our population is getting older, which is good. People should live longer. And with this, we've become much better at identifying sepsis and keeping patients alive. But that doesn't necessarily mean that older patients are having better outcomes. So as you can see here, the frequency of sepsis is increasing in the United States, but it's mostly in patients who are considered older adults. And as I said, in-hospital mortality is decreasing. However, in-hospital mortality is still much greater in the elderly, and these patients are often discharged to skilled nursing facilities rather than at home. And that doesn't necessarily translate to a patient going home, becoming normal, being able to eat and hang out with their families again. Now, this is not because of the fault of the LTACs or the skilled nursing facilities. It's the fact that the patient that goes there has not been able to return to homeostasis. And we are still working on trying to figure out how can we get these patients back to normal. This is a very complex diagram. I'm not going to go into it too much, but I do want you to see that the basic concept of sepsis is that your whole body, not just one organ, not just one cell, whole body has this genomic and cytokine storm. And as you can see, there used to be a lot of early death, but we've gotten way better, thankfully, at preventing that. And there's some patients that do quite well, as you can see in the blue as you sort of go down, and they go home. And these are patients you do not want to intervene on. They would get better on their own. We just need to make sure that their infection's treated, that they eat and exercise, and we don't sort of mess with anything. But there is a subcategory that go into what we call chronic critical illness. And among these patients, these are patients that don't leave the ICU, that still have some persistent organ dysfunction, and then could potentially enter what we call the persistent inflammation immunosuppression catabolism syndrome. Now, what does that basically mean? That's a lot of words. It means that your kidneys aren't necessarily going to get better. Your brain isn't working as it should. Your muscle cells, despite how much exercise and how well we feed you, don't get back to normal. You have low-grade inflammation. Even if you didn't have it before, you still have it. You have immune suppression, almost like you're a transplant patient, meaning that you can't fight infections that before the sepsis you could have totally gotten rid of without a problem. And then you end up catabolic, meaning that basically no matter what we do, your muscle tissue isn't regaining strength. And these patients, as I'm about to show you, can have profound disabilities, and many of them can die within 1 year. So again, just to explain that this PIC syndrome, again, the term created by Fred Moore, as I mentioned before, have these patients that cannot return to a state of homeostasis. And that's despite our best efforts to try and get these patients better. And by using this sort of definition, we are working to sort of do research to say specifically, how do we break this vicious cycle of persistent inflammation, immunosuppression, and catabolism? How can we get patients home to their loved ones? What can we do? So this is some of the data that we published in the Journal of Annals of Surgery. I always find this image in the left corner a little interesting, as I found that in a hardware store, and it's just interesting that they called it septic shock. But we looked at our own patients who have surgical sepsis, because we work in surgical intensive care units, to see what happens between inpatient mortality and 1-year outcomes. So our goal was to look and compare these two. What's been happening since 2 decades ago? Has sepsis changed in the surgical intensive care units? And we did over 300 patients. It was about a 50-50 split with men and women. They were quite sick, and they had typical standard infections that you would expect to see in our ICU. Importantly, they spent quite a bit of time in the hospital. Many of them needed breathing machines. A lot of them needed kidney support. And the 30-day mortality rate was 10%. So what if we break this down by early deaths, rapid recovery, as I showed you, the patients you really don't need to do much with, and those that enter chronic critical illness. Well, compared to previous decades where it was quite high, early deaths now in the surgical intensive care unit are quite low. They're 4%. Then you see about 2/3 of the remaining patients can recover with optimal clinical interventions. But then there's about 1/3 of those that do not return to baseline and end up in this PICS chronic critical illness phenotype or status. Now, how are they different? Well, it looked like some of them are more male, they're older, they were sicker, and they were more likely to require blood pressure medications just to keep them alive, as known as septic shock. And then when we talk about dispositions, a good disposition would be going home or to an acute rehabilitation facility in which most patients go home, as opposed to LTACs and SNF where they need significant care, or the fact that maybe they had an in-hospital death, or they transferred back to the hospital they came from, because we are a quaternary center that takes patients from all over the Southeast to take care of them. And as you can see, there's significant differences. 82% of these chronic critical ill patients had what we considered a poor outcome. This is very important because, again, we have a new category of patients that aren't going home and not getting what they were sort of hoping by the end of their treatment. Using certain scores, this is called the Zubrot score. It's a way you can determine someone's long-term performance after they go home, with 0 being asymptomatic and 4 being severe disability, completely disabled, cannot carry on self-care, totally confined to a bed or chair. As we look here, blue on the right, as you see, with the circles, are those patients that had rapid recovery, and most of them are able to go home and are highly functional. But if you look at those patients in chronic critical illness up to a year out, many of them have moderate to severe disability or have died. If you look specifically, and again on the right side, you can see that comparing rapid recovery, 5% of those patients are dead at 1 year. 41% of our patients have passed away within 1 year when they were septic, despite optimal treatment and everything else that we have done. That's a staggering amount. So to summarize, traditional inpatient mortality may not be the best way to look at anymore because things have changed. That the early deaths aren't what they used to be, thank goodness, because of the way we treat patients. And many patients will do well. But there is a subgroup of these patients that do poorly, do not recover, and have up to a 40% 1-year mortality that we do need to focus research efforts on and ways to get these patients better. And what happens to many of these patients? Well, they have sepsis recidivism. That means they keep getting septic again and again and again, and they keep having to be readmitted. And they have non-resolving multi-organ failure that often leads to these late deaths. So again, as I mentioned, the phenotype of sepsis is changing. Many of these patients progress to PICS. These patients are risk for significantly higher morbidity and mortality within 1 year. And our group and others, but our group at UF Health and the University of Florida is beginning to focus on this syndrome to see if we can get patients better. It's not just our group. This is some data from Frontiers in Immunology. Wanted to show you that other people have looked to see the percentage of patients who have died in-house and after the hospital discharge. So again, many of the patients survive out. And you can see from these multiple studies looking up to 1 year, 2 year, 5 years out, that it can be up to 66% of patients did not survive, even though they were discharged from the hospital and no longer needed ICU care. If you look up in the 2 years, you can see some of them go up to 70%, 56. 5 years out, at a study in the United States, you can see 100% of these patients have passed away. So again, we have much work to do. What happens after sepsis? Multiple things. It's not just, again, the frailty that I was describing to you, but you can again get sepsis recidivism, which is that causes rehospitalization that you see right there, infection, recurrent UTIs, cognitive changes. This is a big problem. It has been shown specifically that for every bout of delirium you have in the hospital, that can be associated with worse outcomes. And sepsis causes significant delirium in many patients that occur. And then this can lead to dementia-like symptoms. So it's not specifically Alzheimer's disease, but there are patients that go home that just not only have cognitive impairment, but can have actual significant issues that resemble what could be an Alzheimer's disease related type disease. So this is a big problem for people. Cardiovascular disease is also a big problem. Your risk for a heart attack or a stroke after sepsis goes up significantly, almost like you had multiple risk factors prior to sort of going on. You can have changes in metabolism, which we talked about before. So despite your best attempts to sort of eat what you need to eat and exercise the way you need to exercise, you might not be returned to normal the way you were before the sepsis infection, so that you can't get better. The immune dysfunction, as I mentioned, is there. There are multiple, it's very complex. There's multiple things that occur, but more needs to be understood about this complex issue to stop people from having repeat infections time and time again. And as I mentioned, people have done different quality of life studies. In general, most of them show that there are lower quality of life. Those sepsis survivors that make it to 6 or 12 months are usually having a lower quality of life if they did not recover well. So again, what happens to the septic patient after a hospital discharge? You can get new infections, worsening cardiovascular disease, suboptimal changes in protein metabolism, chronic inflammation, almost like you were potentially a rheumatoid arthritis patient or a cancer patient, immune dysfunction in a similar manner that like a cancer patient or a rheumatoid arthritis patient that continues to go on, that makes you more susceptible to infections that typically your body would have just fought off without a problem. You tend to have more edema that doesn't go away. Cognitive problems are a big issue for patients, and they'll tell you that when they get home, they're not able to focus and do what they did before they got back. And again, as I mentioned, recurrent infections, time and time and time again, you just can't clear them no matter what best treatments are given to you. So again, what can you do at home? Well, for one, learn the signs and symptoms, okay? And this comes from the CDC, know the signs and symptoms of sepsis. So as we mentioned, shivering, fever, very cold, that isn't due to the temperature of the room. Extreme pain or discomfort that's out of control, that's coming out of nowhere. Acute new onset clammy or sweaty skin. This is not normal, something's going on. Confusion or disorientation, someone that isn't related to someone like passed out, or had a recent accident or something. All of a sudden the person just doesn't make sense. Things aren't going on. This could also be a stroke, so you should be investigating both, but infection can cause a lot of the same problems. Acute shortness of breath. Now again, this can be a heart attack or a PE as well, but all of these require rapid intervention. And a high heart rate that's just you haven't been exercising and all of a sudden your heart rate's in the 130s. Oh, that's not correct. And again, this could be heart related. This can also be related to infection and needs to be treated immediately. So you can learn the signs and symptoms, understand if you're at higher risk so you can be on alert for it. If sepsis is suspected, get immediate medical attention and ask yourself, could this be sepsis, so you don't miss it? Talk to your healthcare provider about optimizing the management of your chronic medical conditions. The better they are treated, the less likely you are to get an infection that could lead to sepsis. And of course, talk to your healthcare provider about being up to date on your vaccines, all of them. This is important to keep viruses from getting out of control so you get septic, or from viruses from invading tissues, making them more susceptible to secondary bacterial infections, which can also cause sepsis. So what can you do as a healthcare provider, if there are any listening today? Prevent infections. So follow infection control and ensure your patients receive their vaccines. And when I say follow infection control, wash your hands going in and out of the room. Take off your white coat if it's not clean. Put on proper gowning when you interact with your patients, especially in the hospital. Do all those things you need to do to prevent transmission from person to person and keep things clean. Educate patients and their families about sepsis. Hopefully this Zoom and others, as well as Sepsis Awareness Month, can get the word out. Think sepsis. It happens more frequently than you think. So rule that out in addition to other things. If it is sepsis or you suspect sepsis, it is an emergency, just like a heart attack, a bleeding trauma, or a stroke. So act fast. And just when you finish the first action, you're not done. You must reassess the patient to see if what you had done has gotten better, or if they need more invasive treatment, which would occur in an intermediate care unit or an intensive care unit. Again, there are further resources. The CDC has some wonderful resources that are here. You can see cdc.gov/sepsis/index.html. And they have multiple things you can do for patients, practitioners, and other things that really help to sort of explain this a lot better. They've done a wonderful job with this. And these are some references for some of the work that's been displayed today. And I would encourage you also to come to our website for the Sepsis and Critical Research Illness Research Center to see what we are up to. And if you want to get involved, or if there are other things you can do to help us fix this problem that affects so many Americans. And on that note, I'd like to thank you all for listening today, and I'm happy to take any questions.
Okay, great. Appreciate you doing that. We have several questions that came in. I'm going to have you go ahead and stop your screen sharing, and then I'm going to go ahead and start asking a couple of them. Are people in the hospital more likely to get sepsis if they have COVID-19?
Well, that's a double-edged question. So first of all, there's bacterial sepsis and there's viral sepsis. And some people would call, when COVID-19 gets really bad, a form of viral sepsis. Now, they don't necessarily have the exact same effect, but that can, let me rephrase that. It doesn't have the exact same effect on the body, but they lead to the same issues, which is that your body organs can shut down and you can get these long-term issues afterwards. So that is a form of sepsis in and of itself if you're having a bad organ reaction. For instance, you can't breathe well because it's cut down on your sort of, and you require high flow oxygen and stuff. There is a possibility that when your lung tissue gets damaged by the COVID virus, that you can get something called a secondary infection, and you get these secondary bacterial pneumonias, which normally, if you didn't have COVID-19, your body would have just taken care of it normally. So in those situations, yes, you can have a much higher risk of becoming septic, because these bacteria that shouldn't be allowed to run around and do whatever they want in the lungs or even other parts of your body, now that certain organs have been shut down, can overcome your normal immune status or your normal immune system and can put you in a state of sepsis. So I would say anyone with an infection of any sort, whether it's viral, fungal, or bacterial, is at higher risk for sepsis in these sort of situations.
Okay. I had another question that came in, and you might have kind of already touched upon this, but does sepsis relate any way to the, I'm going to say it wrong, cytokine storm? That
Yes.
Okay. Does it have, they heard about that early on when sepsis started kind of coming around, and they're wondering, is there a relationship to that?
Absolutely. So we used to actually think that there was sort of this only what's called pro-inflammatory storm, and it was followed by an anti-inflammatory storm, which would explain the inflammation followed by the immunosuppression subsequently. What we've discovered is actually the cytokine storm, which is the same as the genomic storm, meaning the entire body has, at the same time, both pro and anti-inflammation. Your whole body sends everything out all at once. So it's both at the same time. And this cytokine storm is needed in some situations. It's not all maladaptive, so to help the body deal with stuff, but most of the time it's out of control as compared to where it should be to help deal with the infection. And those patients that can whose cytokine storm resolves are often those patients that have rapid recovery because they're doing better, they fought the infection, they get back to normal. Those that are unable, who have a prolonged and exacerbated cytokine storm, and again, that includes everything. And now we found it's almost the entire white blood cell genome, and there's multiple organs involved everywhere that cannot restore homeostasis. These are the patients that tend to do worse, but it is initiated by what the listener was describing, which is a massive cytokine storm that causes these problems in the body. However, you can't just block, that concept of just blocking cytokines is does not work. We've tried it. There's too many of them. There's too many repetitive pathways, and 100% blocking of all of them is also bad for the body. So it's finding this balance in homeostasis for the host to return to where they were is going to be more key.
Okay, thank you. One of the early slides you mentioned osteoarthritis is a potential source of sepsis. Could you please explain the mechanism and how that works?
Well, unfortunately, when the bone gets infected, it's really hard to get rid of it. And it requires as many, hopefully, hopefully not many of the listeners know, but it requires a minimum of 6-week antibiotic course, and sometimes orthopedic surgeons have to get involved and take out the infected area and all these things. But just like any other infection, whether it's pneumonia or a skin infection spreading through your body, or a bursted diverticulum in your colon that's out of control, so there's bacteria going everywhere, the same thing can happen in your bones. And that can lead to, rather than a controlled infection, can lead to an overwhelming systemic body infection. And these are situations where you have to see a general surgeon intensivist and an orthopedic surgeon who will have to remove emergently that infected bone and do some other stuff if it's what's causing that stuff. So most of the time, or hopefully for most patients, osteo is unfortunate, but can be treated locally or in a different way. But there are times when it gets infected and it gets out of control. And this can be especially true in those patients that are higher risk. So if you're a transplant patient, potentially a vascular disease patient who has suboptimal blood flow to some areas of bone, some diabetics can be at higher risk because the bone can be exposed and they're not getting good sort of tissue supply of white cells to sort of get that, and the infection can get out of control. So an infection anywhere can cause that cytokine storm in the wrong situations.
Okay, thanks for clarifying that. Another question that came in, you talked about the colon. So someone says, can a high fiber diet help prevent bowel blockages that are related to sepsis?
I think a high fiber diet in general, the American diet in general, I'm not here to poke, but in general, our diet is too high in fat, doesn't have enough fiber and vegetables. And that's been shown in multiple studies of populations. So a high fiber diet in general is good for you, and it could potentially unblock things. In general, it tends to give people a normal, regular stool, less diarrhea, less constipation. I'm not sure, it's not clear yet whether high fiber in general stop you from having an overwhelming reaction to a POP, whether it's appendicitis or, again, diverticulum. But there is data, at least some data, and it's not clear, that improved diet and improved fiber can improve the bacteria known as your microbiome in your colon. Therefore, when the infection does come, you could potentially have less of a worse reaction, as opposed to having sort of other bacteria there that can lead to your body sort of being suboptimal to begin with to deal with infections. So rather than maybe having a little pop in the colon, I don't know what to call it, that could be easily contained and made into a contained abscess, you may end up having a more systemic reaction because your body was already sort of set up for suboptimal stuff. So in general, does fiber stop sepsis? No. Will it make your bowel movements better? Yes, overall, it's a good thing to do. And there's still much research to be done there.
Okay, great. Could you address post-sepsis syndrome?
So post-sepsis, so there are many names for what happens after sepsis. So one is promulgated by the Society of Critical Care Medicine, which I'm a member, and it's called post-intensive care syndrome. That's PICS as well. In Europe and in America and in parts of Latin America, they also have something called post-sepsis syndrome, which also is similar. And many of these are similar to what I just described, which is a more generalized term of the persistent inflammation immunosuppression catabolism syndrome. And to be frank, if I go up to a patient and I have to talk to their family members and say, by the way, you have the persistent inflammation immunosuppression catabolism, that's not going to make a lot of sense to them. And so that's really more of a scientific research term. But post-intensive care syndrome or post-sepsis syndrome, that is understood. And that basically means that after sepsis, as I showed in those last couple of diagrams, you're not out of the, once you're out of the hospital, you're not off the hook. It's not like removing a cancer. Again, cancer patients have their own issues, whatever, but you don't just remove it and you're done and you keep an eye on it. There are long-term systemic issues that occur in your brain, your muscle, other organs that we are just beginning to understand, where patients cannot get back to normal. They can't function the way they used to. They can't remember what they did. The cognitive issues are there. The frailty issues are there. And what we'd like to do is to have patients, we need a better understanding of the pathophysiology of post-sepsis syndrome so that we can intervene so these patients can do better. And they're very similar things that people are starting to see with post-COVID syndrome. How they get there may be different than a bacterial infection. It's not identical, but the end results with the issues with cognition, the issues with functioning with daily activities, the issues with long-term organ problems, these are very similar. And these are issues that we're going to have to find a way to address so patients can get back to normal and happy, healthy lives.
Yeah. Okay, that sounds like it's quite a challenge for some people. So, another question is, once the sepsis process starts, how long would it be before symptoms are obvious or diagnosable? What's the average kind of time from when you think it occurs to when you might, maybe a person like myself might see it and think, oh, we better get help. What do you think?
That part's, so it's the problem is we don't, unlike trauma where you know exactly where the car crash occurred, it's never clear exactly when the infection started and went from infection to sepsis. So that's not clear, but I would say that when you start seeing the symptoms, you are already septic. So it's already there. The bacteria is spreading through your blood. They're doing stuff. They're shooting around and doing the things. So I couldn't give you a time from when the bacteria in your lungs go to overwhelming and start sending stuff. What I can tell you is that just like acute chest pain, just like losing vision in one eye, that when you have those symptoms and they don't make sense in the context of anything else going on, you are currently septic and that needs to be dealt with immediately.
Okay.
And that's yes. So
All right. Does pneumonia easily turn to sepsis? I think you mentioned that.
it depends. Again, most patients walking around, even older patients, don't just succumb to pneumonia. But when there are other factors affecting it, it can, especially if a patient has a breathing tube down their throat, because your body isn't used to that. That's not the way our bodies were sort of designed. So pneumonia in general shouldn't occur in most patients, but if you have a high risk, it may occur. But if it's not treated appropriately, or you're not getting better, or you're high risk for certain reasons, potentially you take an immune modifier, potentially you're over age 80 and just being an octogenarian, your immune system works differently. If you're a newborn, a neonate, these patients all react differently to infections in the lungs, and these patients can actually go from infection to sepsis much more easily than other patients. Are all pneumonias going to do that? No, many patients can be treated at home. It's sort of different. It just depends on their circumstances. But there are certainly patient populations that need to keep a very close eye, as opposed to one where I was like, oh, here's your Z-Pack, you're going to be fine. Just go back to work when you're feeling better, as opposed to other patients where it's like, you really need to keep a close eye on these things because you could become septic and that needs to be dealt with immediately.
Okay. How does inflammation affect the free kappa chain levels?
The free kappa chain levels?
That's what they typed. I'm sorry. I'm guessing. I'm gonna allow my depth here.
I'm not exactly sure what
Okay.
you're talking about. The kappa chain regarding the antibodies. I'm not exactly sure which part you're talking about. What if that's specifically what the individual is referring to, then sepsis generally shuts down B cells in their appropriate function. So if that's specifically what they're regarding to, your antibody function actually starts to work imperfectly. In fact, every immune system in the body reacts to sepsis in a negative way if you do not get better. And so that suboptimal functions sort of occur. It also affects multiple proteins, cytokines, other things that are called danger-associated molecular patterns and other PAMPs, sort of things like that, that circulate around that shouldn't be circulating in a normal situation. And all these can affect how organs are acting. So that's, yeah.
Okay. Does having a tetanus shot help protect you from sepsis?
In a way, tetanus infection, an overwhelming tetanus infection has its own issues in sort of your neuromuscular junctions. So you're going to die from that regardless of your systemic response. So you need a tetanus shot regardless, because if you get cut, it potentially can happen. It used to kill people in the Middle Ages all the time. Nowadays, it's perfectly easy to prevent that from happening. If for some reason the tetanus doesn't kill you and you keep having overwhelming stuff, then you could potentially end up in a sepsis situation. But I will say other shots, such as your meningococcal vaccine, absolutely, it's not meningitis, pneumococcal. There are multiple other types of shots that can all lead to either viral or prevent viral or bacterial sepsis. And as I also mentioned, many of these viruses damage tissue, which allows secondary bacterial infections that normally wouldn't have occurred. So by keeping up on your shots and doing as your provider asks for that, you can, yes, prevent sepsis from occurring.
Okay. Another good question. Are cellulitis, MRSA, and sepsis related in any way?
They can be. MRSA is a specific type of bacteria that's become more prevalent due to our our use of antibiotics. So we have to take that into account when we treat patients. Not all cellulitis is caused by MRSA, but a lot of it can be in the United States. You have to take that into consideration. If the cellulitis is not locally controlled and starts to spread, and MRSA can do this, streptococcus can do this, even certain types of Vibrio that you get from the ocean and fishing can do this, it can start spreading. And when it starts to spread and is out of control, then you can become septic. So again, when it moves from cellulitis to a more severe infection, yes, they can all be absolutely related. And MRSA, or methicillin-resistant Staphylococcus aureus, can specifically cause this, yes.
Okay. Someone kind of had a follow-up question. Says, I'm not quite 80, but your comment that people over 80 have a different immune system, it makes me ask, how so?
Well, it's not just 80. We tend to do things based on governmental regulation of definitions. So it's not like everything magically at age 65, your body changes. It actually starts to change after age 40, 45, 50, 55, which a lot of people don't want to hear. But again, we weren't necessarily created or evolved to live as long as we do. So it's wonderful that we do. We're not dying in the woods, amongst things that normally would cause us to sort of succumb. So by being able to live this long out, our bodies start to change in multiple ways. And it starts slowly in middle age, but your ability to make the cells that fight the bacteria initially changes. Those cells that you know as helper cells that sort of act as the immune regulators, they become less functional. You have something overall called inflammaging that starts to grow and grow and grow, meaning you have a low-grade inflammation. And this low-grade inflammation can kind of suppress or alter all sorts of things that happen in your immune system that when you're 14 is not an issue. And you have other cells that also change. So I don't want to get too much in the details, but myelopoietic cells like neutrophils and monocytes tend to be emphasized more than these lymphocyte T cells, B cells, as you get older and your body tries to make more of them as you sort of age. And these aren't necessarily the best functioning, the most appropriate cells that you need to fight infection in these situations. And again, most of the time your body does okay. 80-year-olds don't just keel over from a pneumonia. It's usually in relation to something else. But when those other things happen to a 14-year-old, it doesn't tend to have the same effect because of the immune system that's circulating around, as well as the way their organs function. But in these situations, as you sort of move on and on and on, things change. Just to be clear, though, and I just used octogenarians as a term, there's a difference between chronological age and biological age. I treat 45-year-old patients, perhaps with end-stage renal disease, that you could consider chronologically 80. And I have 80-year-olds that take fiber as the person implemented before and run and do. They're quite active, and they probably have the body of a 50-year-old, at least immunologically. So again, it's not just how old you are, but all the environmental conditions, some of your genetics, some of the other things that sort of go on. So yeah, there are things like, not in addition to vaccines, that you can do to make your immune system better so that you aren't necessarily going to succumb to sepsis.
Okay. We have one more question that says, I'm going to kind of rearrange a little bit. Sounds like this person frequently has had some injuries to their lower legs and developed cellulitis. Does that have anything to do, or does that more likely to have them acquire sepsis?
So if the injuries are impeding blood flow or normal physiology in their legs, and this can be true in many patients, such as not just someone had the injury they did, but a vasculopath, a vascular patient, patients that have diabetes, so their blood vessels aren't necessarily distributing the blood as well as they could. Yes, that lack of blood flow and those conditions can also make your white cells not function as well as they can. So yes, you could potentially be at a higher risk for sepsis. That doesn't mean you have to be admitted to the hospital, get a bunch of IV fluids every time you have cellulitis, but you are someone who potentially should keep a very close eye on this and determine, if things aren't resolving the way they would with oral antibiotics or other things, that you should have a higher threshold or lower threshold to actually get yourself looked at and see what's going on. And if there are any ways to address what may be going on in your lower extremities, that hopefully those kind of interventions could occur.
Okay, and we have our last question here. Is there a test for determining your strength of your immune system?
That's a wonderful question. First of all, we haven't figured out exactly what a perfect immune system should be. I would say a middle school child, but we don't understand what they are altogether. So that's been part of our problem, is what should be normal as opposed to what is optimal and what isn't, because it's not all one size fits all. We have different people who have different things from different environments, and some of their immune systems have modified to deal with the environment they live in. So it's not 100%. That's a very interesting way of looking at it. There are people who are trying to sort of identify those sort of things. What we can tell you is it's a lot easier to identify when something isn't working well, because they're clearly not killing the bacteria properly. They're having these overzealous responses in terms of the communication of their cells with these cytokines, et cetera. But I think that's actually a very interesting idea, to create a scoring system. I'll have to look a little more into that. That's pretty neat.
Maybe there's a big donor out there that'd like to help support that research and all that. So I thank you so much for your time today. I know you're a busy, very, very busy person, especially COVID's going on. We appreciate all the work that you've done to help everyone. And thank you for joining us today, and appreciate it.
Thank you guys very much. And again, it's our pleasure. Please feel free to reach out to us if you have more questions. Here at UF Health, we're dedicated to making you